general dentist from the Detroit, Michigan area, and welcome to tonight's webinar. We're going to try to respect everybody's time, and tonight's topic is how to routinely perform extractions and grafting in your office as the general practitioner. And as I mentioned, I'm a general dentist here in the Detroit area. I place a lot of implants. We place about 1,100 implants a year in our practice, which is quite a bit. But I'm a big believer that to be an effective implant dentist, we have to set the foundation for our dental implant work. And that includes atraumatic extractions, which we'll be discussing a little bit tonight, and grafting procedures. And I know there's a lot of confusion about different grafting materials and products out there. So hopefully the next hour that we spend together will eliminate some of the confusion. One of the things that I would like to say before we begin is I'm a very practical person, and I'm going to demonstrate and show you products that I use. There's a myriad of different materials and products out there that you can use, and we don't have the time to go through every single different brand. So I'm going to focus on materials that I've used in my practice for many, many years that make me very competent and predictable in my final creation, so to speak. So our objectives tonight are quite simple. We're going to demonstrate and help you understand atraumatic extractions. And atraumatic is a very important word for me, meaning, what does that mean? Atraumatic. Well, atraumatic to the bone. Maintaining a facial plate of bone is very important in our extraction techniques, especially if we're preparing for a future dental implant. So atraumatic to the bone is important. Bone is gold to me as far as future dentistry goes. But also atraumatic to the patient. It's really nice when we have a positive experience, or our patient has a positive experience in the chair. And I'm going to show you the techniques using the GoldenDent physics forceps, which allow me to remove teeth with very little pressure on the patient. And finally, atraumatic to me. I'm learning to save my back and my hands and my eyes, and any tool that makes me more proficient in removing teeth is an important tool. We're also going to understand site preservation, why it is important to graft sockets. I think that we all realize as dentists that when we lose teeth, bone will shrink. It shrinks down or up and in certain situations, and in the sinus areas, which is a major concern for general practitioners who want to place implants. The sinus floor will actually collapse after a root is removed. So maintaining that socket creates a great foundation for future dental work. And I'm going to give you some clinical and scientific information on different bone grafting materials, and specifically the methods that I use to make my grafting procedures extremely predictable. And here we're also going to demonstrate or obtain easy to understand step-by-step instruction on how to immediately implement predictable extractions and grafting techniques into your practice. And this means if you follow the recipe, so to speak, that we've created in our grafting procedures, you'll have the same successes that I do. Before we get into the program, though, I do want to mention that you do have the ability to type in any questions in the box on your screen. So if you do have some questions, please type them in, and we will get to them at the end of the program tonight. The webinar tonight is sponsored by GoldenDent, the creators of the physics forceps, but they also supply me my grafting materials and my membranes that we will discuss and describe throughout the program today. So they'll have some specials at the end of the program. I'll let Kurt Lawler, who manages GoldenDent, and they will go through the specials and any other questions that you may have as far as continuing education, etc. So extractions and grafting create a huge potential in your practice. For those of you who are interested in surgically placing implants, I strongly recommend it. I think that general practitioners certainly have the capability to understand and place dental implants as well as restore dental implants. Of course, this does take some specialized training, and I do advocate learning the process correctly. There are a lot of programs that you can involve yourself with as far as implant training, and I'm sure Kurt at the end of the program will be happy to share some of that information with you. I would also like to mention that we do several programs at our university, the University of Detroit Mercy Dental School. Actually, this Saturday, we have a big group coming in for an atraumatic extraction course, and this is on live patients. We'll see anywhere between 85 and 100 patients on Saturday, and every doctor will probably take out 25, 30 teeth using the physics forceps. We follow that up with a 2-day program on extraction and grafting, again, on live patients, where we probably see 65 patients in the dental school, where each participant will actually remove teeth and graft using 3 different materials and 2 different membranes. So a very, very high quality, hands-on procedure. You have to get involved as a GP, and it starts with our webinar today. So hopefully this will be informative and motivate you to get started. So let's just go through some of the grafting basics. Socket grafting, simple socket preservation is extremely important in today's environment. Number one, it prevents future bone loss and ridge resorption. As I've already mentioned, when teeth are lost, bone will shrink. How much? It depends on the patient, but it will shrink, which complicates our situation. For those of you who are not placing implants today, a couple of the reasons why you're not is you're concerned about the anatomy. You're concerned about the mandibular nerve and your mandibular canal and nerve, and you're concerned with the sinus. So if we're able to maintain bone ahead of time, it allows us a better foundation for future implants. Socket grafting helps support adjacent teeth and, of course, implants. It helps us plan for future options, such as implants or fixed bridges. We've all had situations where we see concavities created even in our conventional Pontic designs. Fixed prostheses might have a poor aesthetic without the presence of adequate bone. And again, today we're going to demonstrate some very good techniques where we have all 4 walls intact, or if we're missing a facial plate of bone. And we can predictably grow bone today in nearly 100% of the time, as long as we follow the correct recipe that we'll demonstrate today. And we like to say that it sure is easier to preserve now instead of creating bone later. When patients lose a tremendous amount of bone, oftentimes we refer to our surgeon or our periodontist for a much more invasive procedure, where we'll take bone from the chin or from the ramus or even from the rib or the hip to try to build bone. So these simple procedures sure make it easier on the patient down the road, and it helps us to avoid additional surgeries. The procedures that I'm going to demonstrate today are simple, safe, and effective, but they are technique sensitive, and so I want you to follow through carefully. And I understand that these webinars are recorded, and so if you need copies of them, I think that you're able to obtain those. Oftentimes I'll hear, well, my patients won't pay for the grafting procedure. They can't afford it, or the insurance won't pay for it. And you have to remember that patients' financial situations can change with time. And as professionals, we owe it to our patients to discuss options with them. Of course, we can't make the final decision for our patients, but I think if you make the patients understand the importance, the critical importance of socket preservation, they will accept treatment. But of course, there are some financial ramifications here, and hopefully we'll be able to demonstrate that. And you can provide this service at a very cost-effective means for your patients. So very quickly, what are the current bone augmentation materials today? Autogenous, the gold standard. Autogenous means from the patient's own body. As I mentioned, from the ramus or from the symphysis area, from the hip. We can actually harvest bone from a second site. This is the gold standard. It has the proper DNA, protein-rich platelets, protein-rich fibers, the bone building blocks of repositioning. But I think it's very important before we begin that, and I tell this to all my patients, bone is constantly changing over in the body. It's not stagnant. It's not a piece of concrete. It's constantly being changed over. And so when you explain this to the patient clearly, it makes the process more reasonable to them. So what I'll tell my patients is when we put a graft material in a socket, so to speak, what will happen is there are cells in the body, we know them as osteoclasts, will actually invade that graft material and eat it away. And simultaneously, different cells, we know them as osteoblasts, will lay down new bone. So bone building is a process in the body. Again, use the analogy if you break your arm. You're in a cast for 6 weeks and that bone heals and mends and is very, very strong. So regardless of which of these 4 materials we use, the body is going to change it over in a period of time. So autogenous graft is from the patient's own body. Allograft is bone from the same species. Cadaver bone, bone from another human. This is harvested cortical or cancellous bone. What does that mean? Cortical is the hard outer shell. Cancellous is the medullary bone. Our allograft materials are cortical cancellous and can be mineralized or demineralized. This is often a point of confusion. What does that mean? Mineralized means that the calcium and phosphorus naturally in the bone are maintained. Demineralized meaning that the bone is processed so that these many of the chemical processes are removed from the bone. So in today's environment, we're normally using a mineralized cortical cancellous allograft material. It's very, very safe. It is from another human, and you may have patients that will back off of that. They, for whatever reason, religious reasons or fear. There really should not be any fear factors because, again, whatever we put into that socket is going to be replaced in a very short amount of time. When patients may have a problem with using bone from another human, there are 2 other types of graft material. The next one is called a xenograft. That's from another species. Bovine, porcine, pig, cow, even a horse today is used in certain situations. And finally, alloplast is a synthetic material. It's usually a tricalcium phosphate, hydroxyapatite material, calcium apatite material. These are synthetic materials made in a laboratory that work very well in my hands, and we'll demonstrate them throughout the program today. The types of bone available and the products used for each category types. Again, autogenous bone is the gold standard, as I said, but there's a second surgical site. There's a second area of the mouth that's going to be sore. There's also increased cost in harvesting that bone. Another really cool product that we've been using for a little while now is the Smart Dentin Grinder, and you can get information on this from GoldenDent at the end of the program. Here we're taking the roots of teeth, the dentin of teeth, grinding them through a special process and using this material as an autograft. It's the patient's own product, and so we're getting very quick turnover into natural bone. So instead of waiting maybe 3 or 4 months or 5 months for bone to turn over, where we can use it for implants or whatever, we can wait 7 or 8 weeks, and we're finding that we're getting great turnover. And I'm going to demonstrate this. It's a really cool product in a little bit. Allograft, cortical cancellous, we talked about this, mineralized, demineralized. What we'll do is cancellous bone will resorb quicker because it's porous. Cortical bone, the outer shell, will take longer, and we want a process to occur when we're getting bone turnover, as the osteoclasts eat it away and osteoblasts lay down new bone. So the allograft will act as a matrix for new bone formation. Very predictable. In the past, there may have been some concerns, but in today's environment with FDA controls, there really is no scientific concern of harming a patient using cadaver bone when we're doing socket preservation. Allograft comes in a particulate. Again, it's a mixture of mineralized cortical bone and cancellous bone. It's like a powder, usually 250 to 1,000 microns, and it's a dry powder. We can wet it with sterile saline or sterile water, and it will kind of form a gel, which allows us to carry it to the site. You can buy it in different sizes, a half a cc or a full cc or even more. It works very, very well, especially when we have a facial wall that's missing. There's also allograft that's packaged already as a putty material. So it has a collagen binding material there, and it's in a syringe, so it makes it very easy to take this cortical cancellous bone and just inject it into a socket site. So if it's something that is more convenient for you, you may find this. But again, at our University of Detroit Mercy programs, you're allowed to use all these products. We let you use all the products on different patients to find out what you feel is most comfortable for you. Xenograft, the biggest one is BioOS. It is very, very popular. Popular in Europe, popular in Australia. Was popular here. I personally don't use the bovine material because I have found in my hands that the cortical bovine particles do not resorb very well, and so I don't get a good bleeding point when I'm placing implants. That's my opinion, and so I'm not going to discuss it today. As I said, I'm going to show you the products that I use very routinely and very predictably in my practice. Synthetics. I do use alloplastic materials. I think they are a wonderful alternative, and I've never had a patient say, oh, no, I don't want that in my mouth. It's made in a laboratory. It's very safe and effective, and I have found that the products that I use have great turnover and have given me great results over the years, over the last 10 years. Something that you may want to just take note of, and this is a big one. It's called an OSTEOGEN plug. And the OSTEOGEN plug is a very, very effective way of socket preservation. It's also a very cost-effective way, and Kurt at the end of the program can discuss this product with you and the cost. But this is a bioactive material of calcium apatite, and it's concentrated in a bovine Achilles tendon matrix. And what it does is it actually mimics the organic and inorganic components of physiologic bone. And it allows for a scaffolding of keratinized tissue to develop. What does that mean? It means that when I have a socket, a waffle cone, all four walls are intact, and I take this material, which has some substance to it, and I place it into the socket, I don't need a membrane on top, because the matrix that is created with it allows that scaffolding of keratinized tissue. This is different than any other graft material that I'm going to show you, which must be protected by a membrane to prevent invagination of epithelial tissue into that. We all know how a socket heals. It heals from the apex towards the crest. And so it's always a race between bone formation and epithelium ingrowth. And epithelium grows very, very fast. Epithelium will grow a half a millimeter a day. And so it's imperative that we protect our graft material. With this particular product, it's very cost effective, as I mentioned, but it also allows me to get an extremely predictable result. I've done lectures around the country on this product. I've done a lot of histologic evaluation, and we do get bone formation in 3 to 4 months using this product. So keep this in mind, and you can talk to Kurt at the end from GoldenDent on the OSTEOGEN plugs. Another great product that I've used for over 10 years is a product called Cerasorb. It is a synthetic tricalcium phosphate material, And again, remember what I said, osteoclasts are going to eat this away and osteoblasts are going to lay new bone. So it's very biocompatible. I don't get a lot of post-operative complications. I do get tremendous creation of bone. It's also very objective, radiographically objective, meaning you can actually see over a period of time how this material changes over from a opaque material to a normal looking bone product material. It is osteoconductive. It is allowing for a scaffold to take effect. And so again, if you want a synthetic material, an alloplastic material, this is a wonderful, wonderful product for you to use, and we'll demonstrate it in a few minutes. Membranes. Basically, there's two types of membranes. Before I begin that, what I want to tell you is a collagen plug is not a membrane. A collagen plug turns to snot in a couple days. It will not prevent invagination of epithelial tissue into your graft material. So a collagen plug is not what you want to use in these techniques. As I mentioned, I think maybe the third time now, I'm going to show you techniques that have been very, very predictable for me, but it's a recipe that must be followed. If you take shortcuts, that's when we have issues with bone not forming, and it becomes very frustrating for us as practitioners when we don't get the results that we expect. So types of membranes, there's basically two types of membranes, a resorbable and a non-resorbable. Non-resorbable means that the membrane has to be removed, and I usually will remove my membranes in 6 weeks after placement. All it does is it prevents invagination of epithelium into the grafted site. The literature will say we use a non-resorbable material where we can't get primary closure within 2 millimeters. And the second type of membrane that we'll talk about is a resorbable membrane. Well, that's kind of self-explanatory. It's a membrane that will resorb on its own. Now, there's many different types of membranes out there, and as your sales reps come through, they're going to tell you, well, you know, we have a product that's just as good, it's less expensive. You need a membrane that's going to be maintained for at least 6 weeks. So the question you should have for your reps are, how long is it going to last? If they don't know that answer, then I wouldn't use it. One of the products that we use, and we'll get into in a few minutes, is a long-acting resorbable membrane, something that if you want just one membrane in your practice to prevent invagination of epithelium, I'll show you what I think is really, really good. It's kind of unique because it lasts a long time, and it's not resorbed quickly, and it does protect the graft material. The membrane maintains space for the graft material, sequesters PDGFs and bone morphogenic proteins, creates a barrier, as we said, from invagination of epithelium, protects the clot, and assists in wound healing, and protects the site. I think that if you're going to use one product, one membrane, have a long-lasting resorbable membrane. And the one that I strongly recommend is a product called EpiGuide. It's a polylactic acid material. It's trilaminar. It will last a long time. You can leave it exposed, and it will not resorb to the outside environment. So most resorbable membranes, you have to get primary closure within 2 millimeters. But this acts as a long-acting resorbable membrane. What does it all mean? Recommendations, what to use and when. So allografts, we talked about putty or particulates that you can wet. OSTEOGEN plugs, synthetic, tricalcium phosphate. The Smart Dent Grinder is a autograft material. And the membrane that we're going to talk about is EpiGuide products for the cases. So let's go through some clinical cases. That's what you really want to see. When do I use, what do I use in certain situations? So if you have all 4 walls intact, you do an extraction site, you have the mesial, distal, lingual or palatal, and facial wall intact, you can use an OSTEOGEN plug. It can't be any simpler than that. You can place it into the socket site, it can mold a little bit, and you don't need a membrane on top. You can use an allograft material, which is very, very popular in the literature right now. There's a putty or a particulate, but you must protect that allograft using a membrane. Synthetic materials, such as tricalcium phosphate, you also have to protect it with a membrane. And the autogenous DENTIN graft material, and I'm going to show you this, it's just so awesome to see this, has to be protected with a membrane also. If you're missing one wall, which wall are you going to miss? Usually the facial wall. I strongly recommend that you use an allograft, human bone. The synthetic I've had good luck with, or the autogenous DENTIN graft material. And again, we need to protect that site. We, as practitioners, can build a fourth wall. We can grow a facial wall predictably. How? Well, it's very important that we protect the graft from invagination of epithelium. How do we do that? Well, we will make a flap. We will pull that tissue away from the defect. And we must place that membrane a minimum of 2 millimeters beyond the defect. So if that defect is 6 millimeters long, then we have to, that membrane has to be placed 8 millimeters deep into the site. We want that membrane to lay passively, facially and palatal or lingually. We suture it in place so that we don't engage the membrane. I will see my patients in 7 to 10 days to remove the sutures, and my membranes will stay intact. As long as that membrane stays in place, we will get a predictable ingrowth of bone in 4 to 5 months, predictably. The problem that we have as general practitioners is we struggle. We try to force the membrane into a socket, or we'll use a collagen plug because we think that's easier. And the reorganization of the graft to bone becomes less predictable. Predictability is key in my business and in your business. We want to make sure that what we're doing works. When it doesn't work, we get frustrated, and then we think that's beyond our talents or our abilities. And I'm telling you, that's not the case. We can grow bone predictably as long as we follow the proper protocol. We're going to show you that clinically in a few seconds. Grafting instruments, we have a great GoldenDent has a great inexpensive grafting kit that has the tools that I use in my practice. If you're going to do an extraction and graft, it's nice to tell your team, bring me the grafting kit, and it's all there at a very cost-effective way in a nice, clean sterilization tray. Again, I'm not going to go into details with this. I'll let you ask questions to Kurt Lawler from GoldenDent, and he can address the instruments and the cost and all of that. We have a curette. Curettes are very important. When we do an extraction, we have to remove any granulation. Anything that's juicy or purple blood is bad. When we get red blood, then we have a healthy site for grafting. We'll have a spoon and a packer instrument. This allows me to transport our graft material to the site and pack the material firmly without condensing. This is not amalgam. We don't crush the particles. Rather, we're condensing firmly to create a site for bone growth. We will have a periosteal elevator to expose the tissue, and we will have an Orban knife. An Orban knife I use very, very well. Instead of a scalpel, allows me to make very non-invasive incisions and allows me to make the flaps, which I'll show you clinically in a few minutes. I just want to remind everybody, if you do have questions, I know I'm speaking quickly, but we have a lot of material to cover. Please type in your questions, and we will answer those questions at the end of the program today. We have a bone file to remove any spicules, and then we have a little bone container that you can mix your product, a bone carrier, so to speak, to wet the grafting product. We have scissors, and we have a very inexpensive needle holder that works very, very well in most circumstances. We'll have a tissue forceps and then a scalpel holder for disposable blades as you need it. GoldenDent has a new series of scissors and needle holders that are pretty innovative. They have suture scissors, and You know, these I'd really like you to see and demonstrate them with GoldenDent. And again, GoldenDent can go through the process, but it eliminates the possibility of hurting a patient or poking a patient using these suture scissors. We're actually they're very, very effective. And then there's suture scissors that we have that are in combination with a forceps, and then a needle holder and a suture scissor combination. So some really innovative, extremely high quality products that are available. One of the nice things I like about the GoldenDent family is, number one, they're local here in Detroit, and they allow you to try their products for a period of time. And if you're really not happy with them, you can return them. I don't think that happens very often, but that just shows their compassion and their desire to service dentistry at a high level. We all have a tendency to spend money on products, but it's nice to know that if something doesn't work in our hands, that they're willing to work with us. Now let's finally get to some cases. The basics are important to cover. The rest of the program is going to be all clinical, so bear with me here. Let's look at our first case. First case, all four walls are intact. We did an extraction, and here we're going to use an allograft putty material, and we're going to place some membrane, and we're going to show you that technique. So we have a tooth, a cuspid tooth that was deemed non-restorable, required extraction, and we are going to graft this product and prepare it for a future implant site. We have, again, a tooth that is non-restorable. We have a horizontal fracture right at the post. Don't we all love posts as dentists? Recurrent decay. And this could be a very difficult tooth to remove. I don't know how most of you are removing teeth today, but I assume you're taking a periotome or a periosteo elevator, or probably taking an elevator of some sort, taking a force, squeezing onto that instrument, going buccal lingual or figure eight or however you were trained. And oftentimes this root would fracture at the horizontal crack that you can clearly see there right at the end of the post. And then you'll take a lot of time. You'll have to take a burr and some root tip picks, spend a lot of time, and potentially damage that facial plate of bone. Well, I've already mentioned maintaining the facial plate of bone is pretty important to me. It makes my job that much easier if we can maintain the facial plate of bone. We have the Vatek CVCT in our office, and it's a wonderful instrument because we have different field of views that we can determine. And here we're just doing a couple teeth in our view, and you can see that cuspid tooth, that facial plate of bone is paper thin. And so you may say, well, you know, I'm taking cuspids out, they're always going to fracture, and that's not necessarily the case. Here I'm using the GoldenDent physics forceps. The physics forceps is I wouldn't practice without it. I truly can say that I would not practice without it. It has made my job that much easier. It's a set of 4 instruments: upper right, upper anterior, upper left, universal lower. It has two working components. The beak is the shovel-shaped edge that will engage the lingual or palatal aspect of the root, 1 to 3 millimeters subgingival. And the bumper, which is simply a fulcrum point that is placed as high up or as down low into the vestibule as possible. The working end of the instrument is the beak. The bumper is simply a fulcrum. It is not holding the facial plate of bone. It is simply creating a center of rotation. And what I'm doing with this instrument is I'm not ever squeezing the instrument. I'm never squeezing the handles. Rather, I'm holding them firmly, and I'm rotating my wrist in this situation towards the corner of the right eye. I'm creating tension on the lingual aspect of this root. That tension is creating a physiologic response. The body is releasing an enzyme which is breaking down the periodontal ligament. Well, what's holding this tooth in place? It's not bone, it's the periodontal ligament. If the periodontal ligament is destroyed, then the tooth will come up and out of the socket. So with simple rotation, the tooth will pop. You're not going to hear a pop. It's going to release from the periodontal ligament. The instrument is not intended to remove the tooth in total. Rather, it's intended to luxate the tooth about 3 millimeters. Here's a series of 4 instruments that we talked about. I'll simply take a tooth delivery instrument. grab onto the tooth, and I will simply rotate my wrist, and that tooth will come up and out of the socket. And you can see how that was the curvature is towards the facial. And in that CBCT analysis, we showed that that facial plate of bone was very, very thin. I'm telling you here that I have a facial plate of bone, and this is just a remarkable extraction on a horizontally fractured cuspid tooth. Post-op, again, I'm doing this for education purposes only. After removing the tooth, you can see that that facial plate of bone is indeed intact, yet it is very, very, very thin. Post-operative periapical, and in this situation, I wanted to demonstrate to you that that facial plate of bone is indeed intact. And so what I'm doing is making a envelope flap. An envelope flap is, let's use the analogy of a long white envelope, and if you blow into it, you lift the flap and blow into it. It's still attached on either side, mesial and distal, but I'm simply creating a space for the membrane so that that membrane can rest passively. What did I say earlier? The membrane has to be positioned 2 millimeters beyond any defect, and it has to rest facially, and in this situation palatally. It has to rest passively. So here's our EpiGuide material, and you can see I'm not holding this, I'm not wrestling with it. That membrane is placed onto the facial aspect between the bone and the epithelium. I'm then going to take my ALLOGRAFT putty here, and I'm injecting into that socket site. I'm condensing, it's not condensing like amalgam. I'm packing firmly, not crushing the particles. And then I'm going to fold my membrane over to the palatal aspect. Suturing is very important, and you can see many of you probably have tried to suture a membrane in at one time or another, and normally we would do it from the facial towards the palatal, and we would grab onto our membrane. Maybe we wouldn't even notice it until we took the sutures out, and then we pull the membrane out. If the membrane does not maintain itself for 6 weeks, the case becomes unpredictable. I'm not saying it won't work, I'm saying it's not predictable. So this is a technique that I use. Take your needle, it's a reverse cutting needle, and go from the crest towards the facial. The underside of that needle is not sharp, and so it will just slide over. And then turn the needle around and do the same thing from the crest to the palatal. You can see I can't possibly engage that membrane. I'm going on top of it. We use the EpiGuide, which is a long-acting resorbable membrane, and you can see that it is exposed. That's fine. Epithelium is going to grow very quickly, 0.5 millimeter a day. It's going to grow over the top of that membrane, protecting the grafted site from epithelial invagination. It allows us to place an implant in that site, and you can see how the area heals in a very short amount of time. In a few months, the epithelium grows over the top, and we have a fairly healthy site. We're going to expose the implant, make our impression. I know this is not a materials course, but another product you may want to look into is called Kettenbach, Kettenbach. It's a direct impression material, polyvinyl siloxane, different kinds of materials, soft tissue liners, and even bite registration and composite materials. But it will probably save you 30 to 40% over materials you're using now. This is exclusively what I use in my practice. I order it direct, and you can talk to Kurt at the end of the program about where to get more information on specials with this. But you can see how clean that impression is of my impression coping for my implant. And eventually I'm able to restore this missing, atraumatically extracted, grafted, implant placed, implant retained crown. Amazing technology that all of you here listening today are fully capable of doing. Let's look at the OSTEOGEN plug. This is probably the easiest and simplest solution. Again, we have a tooth that's deemed non-restorable. We've created some great separators through GoldenDent. The ones on the top are serrated elevators, and it allows us to cut through the periodontal ligament almost like an Orban knife. The separators are very thin, but with a very, very strong handle. They're anodized, so they're very, very strong. They're not going to bend on you. We have a bayonet, which allows me to remove root tips very, very predictably. Just a great series of instruments that if you want to do this work, you should have in your armamentarium. So here we're taking our bayonet, and I'm just going in between the tooth. And this is a distal elevator that I use that Dr. Golden created to remove the bone from the root surface on the distal aspect of a molar tooth. I don't know if anybody here listening has taken a first or second molar out and removed a big part of the tuberosity area. Very, very alarming, and this kind of separates it. Wonderful, wonderful tool. You can see it, the shape of it, and I'm actually elevating the bone away from the root of the tooth quite deep. I'm taking my physics forceps. The beak is placed on the palatal aspect, the bumper into the vestibule, rotating and luxating the tooth about 3 millimeters, taking my tooth delivery instrument, and look at the divergence of those roots. You're taking a very difficult extraction and making it quite simple and completed in a matter of minutes. The OSTEOGEN plug, as I mentioned to you, is calcium apatite in a bovine Achilles tendon matrix. It's fairly firm. It's not like a collagen plug at all. It can be cut. And here you can see I'm simply taking it to the site, packing it, and suturing in position. There's no membrane in this situation, and it will heal and convert into bone in a very short amount of time. Another case, a non-restorable tooth that we're going to remove. Another product that we like to use, I like to use a lot, is from a Nutra, and it's buffered anesthetic. It's a lidocaine mixed with sodium bicarbonate, and what this does is it brings the pH up to about 7.2, which is physiologic. So I can honestly tell you that about 80% of my patients notice a marked decrease in the amount of discomfort with our initial injections. I'm not using topical anesthetic anymore. I'm not using the gel or the super gel or whatever. I'm simply using a buffered anesthetic. Here we're going to, again, use the physics forceps to luxate the tooth, remove it atraumatically. I'm going to curette, remove any granulation, any purple blood. You can see I kind of molded my OSTEOGEN plug into a socket form. I'm placing it, packing it, suturing, and this is what it looks like immediately post-operative. You can see it's rather radiolucent, but over a period of time, in 3 months or so, the epithelium will grow over the top. It will not go into the graft material. That bovine Achilles tendon prevents invagination of the epithelium. And you can see over a period of time, the site is transforming into bone. We said earlier that the way this is going to be, the bone is going to form is from the apex towards the crest. So the crestal area is not as mature as the apices, but you can see the definite difference in radiographically of the conversion of bone. Now we have a site for a dental implant. I think we can all agree, even if not doing any grafting now, OSTEOGEN plugs, it can't be any simpler than that. It's a great way to start. Let's keep going with case number 4. We have all 4 walls intact, and here we're going to use the autogenous dentin graft membrane. So we have a series of teeth that are deemed non-restorable. We're going to remove these teeth atraumatically using the physics forceps. Here's our roots, and what I did was with this dentin grinder, I'm simply cutting off the coronal portion of the teeth. I'm just going to use the roots. You cannot use this with root canal treated teeth, no gutta percha, no amalgam, no composite. So those materials must be removed. Here you can see I have roots that have been scrubbed clean without any issues. And here's our socket sites. Now for education, I'm going to go ahead and flap this using my Orban knife from my GoldenDent grafting kit. I'm flapping facially and lingually. I'm contouring the bone using my bone file. And this is what the DENTIN grinder looks like. It's a series of disposable tops that will actually do the grinder. There is a DENTIN rinse, which is a sodium sodium hydroxide in 20% ethanol. And then there's also a rinse, which is simply sterile saline that processes the dentin. This is an autograft. This is the patient's own teeth. So we're putting the teeth into the grinder, and these are the particles that are produced. We get a tremendous amount of graft material for very little cost, and the whole process takes about 15 minutes. We'll take that processed particulate, and we'll use our dentin cleanser again, which is sodium hydroxide with ethanol. We'll simply soak it for about 10 minutes, dry it off, and then we will rinse it with a buffered saline, and we create a particulate almost like a gel. Here I'm taking it to site with my carrier using my plugger to pack the graft material to the sites. And then I'm going to take my EpiGuide graft membrane and place it, again, beyond any defect on the facial, rest it onto the lingual in this situation. It's very, very passive. It's not going anywhere. We're suturing the site. 1 week post-op, the site heals beautifully. You can see after 7 weeks in this situation, again, for education, a CBCT was taken of the area, and you can see how we do have the beginning of formation of bone, which allows me to make another incision and strategically place my dental implants in hard bone. And I can tell you that this felt like bone. It was just a great experience. In 7 weeks, we converted those sockets to an ideal site. Suture again, and we'll allow that to heal. Depending on the type of implant, the process becomes very routine. Now, let's say we lost a facial plate of bone, which happens, right? The bone is thin in the anterior. We can lose a facial plate of bone. So let's look at this patient that presented. We have a distal defect, again on a root canal treated tooth, probably a horizontal fracture we're going to aesthetically remove this tooth. You can see a little bit of pus drainage coming from the facial. I'm engaging the GoldenDent nutriment physics forceps, which I love. It just makes my job so much easier. I see an instrument of choice. I'm engaging the beak onto the palatal aspect, putting the bumper as high up the vestibule as possible, rotating my wrist towards the eye, never squeezing the instrument, rather just simple wrist rotation. The tooth is luxated. We're taking our tooth delivery instrument and we create a socket. Now, why is this important? This is very important in the aesthetic zone because we want to maintain the interseptal bone. The interseptal bone is what maintains the interdental papilla. Without interseptal bone, that interdental papilla will shrink away. That's just physiologic. But this is the important shot. Here we take a post-operative radiograph. You can see where the tooth was removed and the defect. Curette, but look, you can see my curette is showing through. I have a defect there. I have no facial wall. And you have to know this. You have to know if you have a facial wall or not. If you don't have a facial wall, what are we going to do? We're going to elevate that soft tissue facially and palatally, and we're going to graft the site. So here we're taking our particulate and wetting it. We're going to use our EpiGuide material. I'm just cutting it and contouring it to site. I can wet it. When I wet it, it kind of absorbs right onto the ridge. I'm taking my Orban knife and very carefully going around the teeth and elevating. I have, taking my periosteo elevator, I have a facial defect. I have no facial wall here. However, I do have a palatal wall, and again, I know this is not an implant course program. We can do that at another time, but I'm going to take my, my dental implant and I'm going to place it palatally, about 3 millimeters, from the facial aspect of the adjacent teeth, engaging the palatal wall. I think we can all agree with this photograph. Even though I have stability of my implant, I do not have a facial wall. You can see all the threads of that implant. So what did we say earlier? We have to have a membrane. We have to protect our graft from invagination of soft tissue. You have to follow these rules. How far beyond the defect do we have to go? The answer is 2 millimeters minimally. So here I'm placing the implant, and again, I'm elevating that tissue, placing my membrane beyond the defect. That membrane is passively placed. It's not going anywhere. I'm taking my graft material and I'm grafting the facial aspect between the implant and the membrane. You can see my graft material. I'm folding over the membrane onto the palatal. Now, if you don't have enough membrane, if it's not long enough, you can take 2 pieces and overlap them. You can overlap these membranes. My suture technique is always the same, from crest to facial, then from crest to palatal. And we are suturing the site. You can see that the membrane is exposed to some degree, but we grew a wall, and our implant is going to integrate. 1 week post-op, here for appliance, you can see that membrane, you can still see it, but it's in place. It's not going anywhere. It's passive. 4 months post-op, you can see that the implant is showing through a little bit, but we have good epithelial ingrowth. We're exposing the implant, making an impression, allowing that site to heal. Here we're using a zirconia abutment. You can see my margins are all in all my implant courses, my prosthetic courses. You'll see how I design my cases. My margins are just at or just slightly subgingival, and the final crown is in place. Certainly adequate in a very, very difficult traumatic situation, but certainly within the capability of everyone here. Another 3-wall defect with that tooth needs to be removed. 2 teeth need to be removed. We're going to use the physics forceps to remove these teeth very atraumatically. Again, curette. We don't have a facial wall. We don't have a facial wall. Make our envelope flap. You can see the tremendous defect there. Take my graft material, my membrane. I place my implants immediately, graft between the defect and the membrane. My membrane is very passively placed, sutured into position. With time, it will heal. We're going to make our impression, and we can make 2 wonderful fitting crowns in those situations. I'm a couple minutes ahead of schedule. I want to thank GoldenDent and Amplify Dental Training for sponsoring me today. I know we covered a lot of material very quickly. I encourage you to talk to Kurt and maybe come to one of our courses at the University of Detroit. Detroit is a wonderful city. It's growing quickly. Our airport is phenomenal. The dental school is literally 20 minutes from the airport. You can come in and take our atraumatic extraction course, or on another date take our 2-day live patient extraction and grafting programs. And again, where each of you will work with at least 3 different materials and 2 different membranes on live patients. It's a great way to elevate your career. And I'm telling you, this is going to be very financially rewarding to you, but also very exciting. What we do as dentists, as general dentists, is very difficult. And it's really a lot of fun to learn new techniques, and especially techniques that benefit your patients in the long run. Certainly within the realm of all of you doing these procedures, as well as I do, we just need you to, we need to teach you and reinforce the recipe, so to speak. So at this, I'm ending right on time. I'm going to turn it over to Kurt Lawler from GoldenDent. Maybe there's some questions that you may have I'd like to address, and then Kurt, if you can go through maybe you have some specials for the listeners today.
Yeah, thanks, Tim. I appreciate it. Hello, everybody. My name is Kurt Lawler. I'm with GoldenDent. We're based here out of Detroit. I see a lot of regular names and people that have joined our webinars on a regular basis. We appreciate your time this evening and investing about an hour, hour and a half with us, and we hope you enjoyed the presentation. I'm going to go over just a couple of really quick slides, and then I'm going to get to the question portion. And as I'm going through these slides, if anybody has any other questions, feel free to please type them in. I do have a pretty good list of questions here, which we'll get to in just a couple minutes. But if you have a few other questions, please feel free to type them in the next 3 to 4 minutes here, and we'll get to them shortly. So one thing I just wanted to go through is the atraumatic extraction instrumentation that was discussed. I know a lot of folks that are probably in the line or maybe already using the physics forceps, but I just wanted to clarify kind of what the sets are and what they consist of. So this is our most popular set of instruments. This one's been around now. It's hard to believe, but it's been 10 years. So this came out in 2007. The design has always been the same. It just has a little bit of a different finish. They're all made here in the USA, and over the course of the 10 years, they've evolved a little bit, but for the most part, they're the same 4 instruments. You have an upper anterior, an upper right, and an upper left, and one lower. So this is a great set if anybody is interested in the physics forceps, trying to figure out if this makes sense for them. As Tim mentioned, we have really favorable product or policies here at our company that allow dentists to try our products with no risk. This one has 90 days. So you got 3 full months to use it, see if it's a right fit for you, see if it's saving you time, and it's a good product clinically for your practice. This would be the set that I would recommend. Standard series set, it's going to work upper, lower, second molar to second molar for the most part. If the patient has a smaller mouth or limited access, you may not be able to get to second molar sometimes with this set. But this is a good set to start with, like I said, with a 90-day trial period on the product. This is the molar series. We didn't demonstrate this evening through any clinical cases, but they work in the same way. You know, no squeezing, wrist rotation only. This is a little bit of a different angle, which will allow you to access the posterior teeth a little bit easier than you may be able to with the standard series set. So this is really limited for erupted third molars, what we like to call hard to reach second molars. And of course you can use it on a first molar, but I think anybody that's using both of our sets now will tell you that you're going to get much better leverage from the standard series set, and that's the instrument you're going to want to use when you can, assuming you can get access. But this set serves the purpose of getting further back and will allow you to reach erupted thirds and hard to reach second molars. So I just want to clarify real quick these instruments. These are a little bit newer for us. We've had these for, geez, I don't know, maybe about, I think 6, 7 months. Some dentists have asked us for products like this. So in the past, we've always said with the physics forceps, you never need to elevate or really do anything in advance because the physics forceps is really an elevator. It's not a forcep. However, with implants and wanting to preserve bone and everything else, of course, it's always a good idea to take maybe some of these pre-steps prior to the physics forceps, where if you want to separate the tissue or elevate a little bit in advance, these separators have been really popular for us, where people will now use these instruments in advance of even using the physics forceps to make it even easier than it may be with just using the physics forceps. The first 2 on there that say S6 and S7, those are new for us. Those are micro-serrated tips. So that instrument's going to be very lightweight in your hand. You're not going to want to use any force with that instrument. They're little saw blades which will allow you to kind of scoop around the tooth, so to speak, to separate the tissue. And it'll ensure when you do the extraction that you're not going to have any tearing of the tissue or any damage of the soft tissue. The other separators, which are separators 1, 2, and 3, that Tim demonstrated through one of the cases, those you're going to use obviously a little bit more force with them, and they have more weight to the instrument. They have a flat end, which allows you to put the handle into the palm of your hand and use a little bit of apical force or pressure to elevate the tooth a little bit in advance. So the bayonet is by far the most popular instrument, which is the one, the second from the bottom. It has nice like sharp claw type teeth, and it's a great instrument prior to using another extraction instrument. Real quick, you know, this is the kit. I mean, this is a super fair price kit. It allows, if you want to have your grafting instruments together, you know, this is an inexpensive kit, but it's also a high quality kit. I mean, it's $467 for a whole kit of 10 instruments and a graft cassette. So if somebody's looking to keep their graft instruments all in one place, or maybe you're just getting into graft, this is something you can learn a little bit more on our website. These instruments, for anybody that's been following us for a number of years or joins our webinars on a regular basis, this Flex series is new for us. These instruments have been clinically tested for a long time. They're all designed by dentists. These are made with the highest grade stainless steel you can purchase. Each one has very special and unique features. As Tim mentioned, when you're removing a buried suture, the tips are round or not sharp, and you can go and easily remove a suture that may be even buried in the tissue. That's that FSS instrument that's shown there. There's other really great instruments that have a suture scissor and a forceps combo, or a needle holder and a cutter on it to allow you to cut the scissor. So everything we do here is to try to make, you know, your job easier and more effective and more predictable, as Dr. Kosinski mentioned in the presentation. I encourage anybody that maybe is already a customer of ours or has a lot of our products, take a look at this new Flex series. There's about 15 of these instruments, and they really are quite special and unique. Or if you're at a trade show in the future, feel free to stop by and we can show you how these work. All right, OSTEOGEN plug. I saw a couple questions. People were asking, what is the cost per bullet? Do you have to use a membrane? The answer is, with the special this evening, they're $42 a bullet, which you really can't get much cheaper than that with a graft, and it requires no membrane. So it's a great option to get involved in grafting, or if you're already grafting, it's a really simple product to use when all your walls are intact, and it's extremely affordable to you, the dentist, to use, and it's also more efficient for you, where you don't have to actually place a membrane. The dent grinder, I think we talked about this in, you know, through a case here. I'm not going to go into this in too much detail. Our website obviously has tons of clinical cases, videos, and photos. But some of the questions that did come in are, people are asking kind of, what is the cost per use? On this product, as it says here on the slide, it does cost you around $49 every time you use it, which is still going to be a very affordable option, as well as very good clinically, because it produces 3 to 4 times the volume of the tooth in particulate. So if you have a couple more teeth or a couple anteriors in there, I mean, you may find that you're going to have 8 to 10 cc's of particulate, which is a ton. I mean, we find most of the time you're never going to. So great sense finding teeth in a row. I mean, for $49, you really would $50, but type material. So something to consider. I know we've had good feedback on this product. Amplify is our program, our education GoldenDent. I encourage anybody that from Dr. Kosinski on allowing to add the course offerings. This is Dr. Kosinski helping a couple of our attendees at a course we did just a couple months ago. Here's Dr. Nazarian, who's our other instructor, helping a couple of the attendees at our AMP1 program. You can see here the facility is very nice. You have your own operatory. There's plenty of room. We get a ton of patients here in Detroit, so it's a very live patient program. You know, no fluff, and we really allow you to practice on live patients, which is really no better way to learn. Here's just a picture of Dr. Kosinski in the classroom component at our AMP2 program. We do some modeling work in the morning on day 1 before we head to the clinic floor for all of day 2. So the last slide I want to go through here, and I'll get to the where you can order here, is, so if we're investing your time with us this evening, we know your time is valuable. We appreciate your time, and so we always want to offer a special promotional offer. If anybody's interested in any of our grafting materials or some of the instruments that were demonstrated this evening, or even our educational courses through Amplify, you can use the promotional code, which is it's GoldenDent 15. So it's just GOLDEN, the numeric 15, and you can save 15% on any of our products or educational programs. It's actually a great deal. It's even better than the trade show pricing that we offer throughout the year at the different trade shows we attend each month. So I encourage anybody to take advantage of that. GoldenDent 15. You can visit physicsforceps.com as our website if anybody wanted to take a look at our products or take advantage of that special. Or of course, you can call us at the phone number listed on the screen. We'd be more than happy to help you with any questions you may have. So our phone number is 586-585-1210. So the one thing I do want to mention about the special, if I can get back here, sorry. So this special, we do it for 24 hours. It's a good special. It's 15% off, which we don't normally do. So it's a limited special. It's valid through tomorrow evening at midnight. So if you're going to take advantage of it, you got, I guess, basically the next day to think about it and see if it's something that's interesting to you. So anyways, let me get to the questions. I know everybody's been typing the questions in, and again, I appreciate everybody's time this evening. So Tim, I'll try to organize these. I'm going to go through OSTEOGEN first. There's a bunch of questions on that. The first question is, these are kind of related, I guess, but somebody asked, how do you suture with the OSTEOGEN? Somebody else also asked which type of sutures you use, so maybe you can answer that at the same time. And then, do you need primary closure?
Great questions, Kurt. You don't need a membrane with the product, with the OSTEOGEN plug. I will suture over the top. My suturing technique, I demonstrated a couple times, is always the same. I go from crest to facial, crest to palatal or lingual. I'll just do usually a cross link, 2 interrupted, making an X just to hold it in position. Epithelium grows very quickly, so it'll hold the material down in place very nicely. I do bring the patient back in a week to remove sutures. And no, you do not need primary closure. Again, epithelium grows very, very quickly. I use Vicryl almost primarily, or Villet material. It resorbs to water. It's very non-inflammatory. It's a little bit more expensive than, say, gut or silk, obviously, but I find that it works really well in my hands. And you know, as dentists, when we like something, we have a tendency to use it routinely. So that's the product that I like to use.
Okay, perfect. We had a couple questions about this first one's related to OSTEOGEN. So people have just asked, you know, how long do you normally wait for implant placement? And maybe you want to address that in general. How long do you normally wait? And I guess, does the situation change with OSTEOGEN?
So you know, bone will convert. It really depends on how big the defect is. But I would probably say 3 to 4 months routinely, never more than 6 months. And as I mentioned, you can actually take a radiograph, a digital radiograph, and determine the amount of bone transformation. You can see how the material will actually radiographically change to an opacity similar to natural bone.
Okay, perfect. Let me keep going with, I guess, some grafting. You know, somebody was asking about, you know, from a past program or some literature or somewhere where they read, I guess they said they were led to believe that synthetic materials don't resorb, and it's not a recommended product if you were planning on placing implants in that site.
Absolutely not true. I've used synthetic materials for probably over 20 years. The Ceresorb material, the tricalcium phosphate, for at least over 10 years, and I've had great results with it. I do have issues, and it's only a personal issue, with bovine materials, the xenograft materials, where That is the product that I have difficulty routinely and predictably placing implants in.
Okay, perfect. For the DENTIN grinder, for using extracted teeth to make the DENTIN particulate graft, we have some questions on like which type of teeth should you not use. People ask if they were like dead or decayed teeth, or necrotic, or maybe endodontically treated. I guess, what are your thoughts on that?
So the process is no filling material, no amalgam, no composite, no gutta percha. Decay really isn't an issue because you are processing it. But what I'll do is I'll just remove all the decay. I'll take the tooth, scrub it, and I'll remove any gross decay, or I'll just cut the coronal portion out and use the dentin of the root itself.
All right, perfect. Some people asked about, is the dentin grinder worth the time? I guess to prepare the graft. I know you mentioned in the presentation it's like a 15-minute process. I guess some people ask, is this something your staff could do, or is this something you're doing yourself personally? And I guess, have you had any issues with finding it's causing a delay, or I guess can you explain the logistics, I guess, of using the
Kurt, yeah, that's a great question. It's just so neat, and the patients are so responsive. Using their own body is just awesome. And what I'll do is I will remove the tooth and hand it to my assistant, and they will do but I will processing as I'm preparing the site. So I'm curetting and cleaning and flapping and getting my membrane ready and all of those things. Do you ever press your snooze alarm in the morning? That 10 minutes, it goes like an instant, and the preparation of bone, it's just such an awesome technique. And what's nice about it, for those of you still listening, is the turnover because of the genetic components in the autograft material. We're getting turnover in 7 to 8 weeks as opposed to 4 to 5 months. That's significant in a lot of situations.
Yeah, absolutely. Yeah, I think that makes it worth the time to prepare the tooth for sure. A couple people asked some questions about OSTEOGEN. Do you place it dry? Do you wet it? How is it placed in the socket?
Yeah, no, I just place it. It's in a socket is usually there's blood in there, so it absorbs the blood very, very quickly. But I do not wet it. I just kind of finger pressure socket.
All right, a couple of physics forceps questions. Some people say they struggle with, like, they see more and more endodontically treated, extracted, or brittle teeth. How
and I wouldn't practice without it. As I'm getting older, saving my hands and my back are critical. I think it is. I think that we're trained, our muscle memory is trained to squeeze a force. Didn't call it a forcep. I know you said it's an elevator. I wish that's what we had called it. But not to squeeze the handles and letting the beak do the elevating on the palate tooth. I find it to be the most effective instrument to remove teeth. It's just in my hands anyways, but I think it is technique sensitive, and I encourage people to come to the course if they're having issues with it. I think having somebody mentor you with the product change the way you.
All right, and then for like broken down or teeth that are at the gum line, can you explain how you engage the beak?
Yeah, well, the only if you can 1 to 3 millimeters subgingival. So if you have a broken tooth or a decayed tooth, you have a point on the lip, and I'll simply take a 557 long surgical burr and the lingual or palatal aspect of the root so that I can. You have to have a purchase point.
Okay, perfect. And then just to clarify, I guess, is that that's at the expense of the tooth, or you're removing bone?
No, you try. Bone is gold to me. I'm trying to make the purchase tooth surface.
Let me just looking through here real quick, see if there's anything else we haven't covered. I guess just your flap. Some people ask about the flap design. Can you just go over that?
Yeah, you know, trying to be conservative with my flap. Again, I just need to see the defect, if there's a facial defect, and so I try not to do vertical incisions, especially in the aesthetic zone. So I'm simply going around the tooth with my Orban knife or with my serrated blade and elevating the tissue away from the tooth so that I can see the defect completely. You have to see it. You can't guess. You have to see it, and try not to make vertical incisions if possible.
All right. A couple of these we can probably respond to later, but some people have been asking, there seems to be a lot of questions on suturing tonight. Needle size for sutures.
Yeah, you know, I think that's your preference. You know, to be honest with you, I couldn't tell you offhand. You know, which ones.
The ones we have in our course are 3.0 or 4.0.
Yeah, 3.0. That's the thread, and the needle type is I don't remember. Sorry.
Yeah, no problem. All right, we'll whoever asked that, we'll follow up with you through email to get you that answer if that's okay. All right, I think I said, Tim, you like this last. Somebody did make a comment. It says, who takes your awesome photos? They look great.
my lovely daughter Jessica, who makes me look really good. Thank you.
All right, well, all right, I'll do one more here, and then I know everybody's time is valuable, and I'll let everybody go. I think we were supposed to end around 9:15. It says, would you recommend DENTIN grinder an abscess? I don't know if it changes your view on that, or I guess the question is about grafting for material or sockets that have an infection.
Yeah, I have no problem. I don't put implants in infected sockets. I do graft. And I think, Kurt, the best analogy that I make is if you have a hangnail, if anybody's had a hangnail on their foot, you can be miserable. It can hurt like heck, and you soak your foot and you clip that nail, and 5 minutes later you forgot that you ever had a problem. The body's an amazing thing. I think it's imperative that you get all that mushy tissue out of there, get the purple blood out of there. But yeah, the body will heal very, very quickly. Grafting in a infected site is not the issue.
All right, perfect. So again, I'm going to, I guess we'll wrap this up for this evening. Everybody will receive, that joined this evening, a replay link, either this evening or by tomorrow morning. And then also be patient with us. We have, you know, we always have upwards of 800 people or so that register for these webinars, and we'll be sending your CE credit through email in the next couple days. So please just be patient with us on that. And again, if anybody has any questions on anything discussed this evening, our phone number is still on the screen, and our website's on the screen also. That has a lot of informative information. Golden15 is the promo code for 15% off. And I'd like to thank Dr. Kosinski for the excellent presentation, and everybody for investing your time with us this evening. Have a great night, everybody.
Have a great night. Thank you.